We're going to go on to the next segment, which is part 2 of my interview with Michael Dinneen, and then we'll come back and speak for a few more minutes with Martin Entwistle. So let's go ahead and roll part 2 of that interview. So does that mean that there would be, say, one person who is ultimately responsible for coordinating your health care, no matter how many different doctors you went to see?
That is the goal. That is what's missing in healthcare in the United States right now. There is no one who is responsible for all the aspects of an episode of care, from the time someone says there's something wrong to the time that you're all better and back to your fully functional state. And if we could, if that could be where the country goes, that says there's like, one person calls it an offensive coordinator, so that all the players on the team that takes care of you, somebody's making sure they're all doing their part and they're all working together to work like accomplishing a play in football.
Now, how would this work from the standpoint of the patient? Would this person who is ultimately responsible for you have a personal relationship with you or know you? Or
Right. In some cases, we think that the centerpiece of the accountable care organization is something called the patient-centered medical home. And there you would have a personal physician who would be the architect of all of your care. But for people with more complex illness like cancer or multiple chronic diseases, you might need what's called a case manager or a care manager that would have that relationship to you and could in a more intensive way reach out to all the people that are involved in your care.
Now, the fact that you create an organization and you give somebody this title of being in charge of your health care, does that in itself make it happen? Because to manage a large caseload, for example, it's hard to see how you could spend a lot of time on any one individual.
Right. One of the things that we're that is a learning in trying to go this way is that we've been underspending in this country in primary care, and so we've forced primary care doctors to have very large panels of patients and insufficient time to really do what's necessary to help them chart their course for health. And so some places, there's a group in Atlantic City right now that have actually doubled the amount that they're spending on primary care. And by doing that, what they've managed to do is reduce the amount of inpatient admissions. So the total cost of care for the patients has been reduced, while the amount that's been spent on primary care has actually been doubled. Because what we think now is that if we got much better primary care, we'd essentially be emptying out hospitals in this country, because a lot of the hospital admissions are due to lack of coordination and lack of good management of outpatient illness.
What do you think is the most wasteful part of the healthcare system? There are often proposed cuts here and there on little things, but what kind of area do you think would be best to cut where we could achieve the most savings without compromising care for individuals?
That's really risky. So most people that have studied healthcare costs in this country would say that approximately 1/3 or more of all healthcare delivered in this country is waste. The problem is identifying which that 1/3 is, because the other 2/3 are very valuable things that we're doing to help people get better once they've gotten sick. And I think that many of the efforts to cut out waste have been like taking a sledgehammer to something where we really need a scalpel. And what we're hoping to do is to attack this in a very thoughtful way. So the president this year, President Obama, has actually just yesterday announced a new program where the effort is going to be primarily on eliminating unnecessary readmissions to the hospital. So about 25% of people in the Medicare age, if they've been admitted for congestive heart failure, they'll be readmitted within 30 days. We know that's unnecessary in many cases. So we're going to focus in on those people where there's both suffering and costs that can be avoided. Because almost everybody would agree, if we can do better outpatient care after people leave the hospital and avoid a readmission, that's both improved quality and reduced cost.
So is the ACO largely an administrative type of organization, or is it involved in actually providing the care itself?
Some of us who just were on a panel talking about accountable care organization wonder if that term really ought to be used. Maybe we should just say accountable care. That really it's about moving from where no one's really accountable for the care of a person over time to identifying that person who feels accountable and then collaborating with others to get the best outcomes at the lowest cost.
Okay, that was part 2 of my interview with Michael Dinneen. Now, he said something about having one person in charge of your medical care. Does that relate to what you're doing at PAMF? You might have a lot of different doctors looking at a patient's medical records, but is there one person who is responsible for making the ultimate recommendations?
Yes, that's a model that we are following and trying to move much more towards. The question is, who should that one person be? In many cases, the obvious person is the primary care physician. But in other situations, it may be another member of the team. You heard him talk about a care coordinator or a care manager. So I think what we're thinking about is a flexible team in which the patient has got an input as to who is on their team, where they identify the people that are important to them. The person that's the leader has got to have the responsibility for ensuring the outcomes for that individual, and positive outcomes, positive experience. And the obvious person is the doctor, but not always will that be the case.
Now, sometimes doctors might have different opinions. That's why they always tell you to get a second opinion. What would happen in a case like that? Would someone say, well, I'm the leader, so will only present my opinion?
Well, that's what the leader of the team has got to be able to broker, if you will, to help the individual make choices between the options that are available to them. So we need to bring in the idea of advocacy for the patient, to help the patient make decisions that they buy into and they feel are best and appropriate for them.
Do you see anything in the future like video conferencing, for example, where you can talk to your doctor or maybe several doctors at once without actually having to show up at the office?
Definitely. I think there are quite a lot of new technologies such as that have got a strong role to play. Again, we've got to be flexible. They're not always appropriate for all patients. We've got to learn when to bring them in and when they have a positive role to play and when they may get in the way of the care process.
Do these tools also help the doctors perfect their own craft just by giving them more exposure to another and knowing what other doctors are thinking? So they might be less isolated. They might sort of have a synergistic relationship with each other.
Exactly. I mean, when we're very busy people, it's hard to get together, it's hard to share experiences, which in past days used to be easier to have rounds and meet and learn. So that's an important dimension, absolutely.
Have you already gotten much feedback from patients as to how well they like the system and how much they use it?
Yes, we've got some very good feedback from quite a number of patients, and we've learned that in other situations, as I mentioned earlier, it isn't perhaps the most appropriate approach for them. And we have to take a different tack with them and work out how we take a more supportive process without necessarily using all the tools. We shouldn't just impose them on people because we think they're the best way to go.
We're almost out of time, so this will have to be the last question. Some people think that the patient should be the empowered one, the one who's ultimately responsible for his care. Is this model neutral in that regard, or?
We actually call our program Empower. It is about trying to empower the individual to make decisions, have the information, and take responsibility for their health and outcomes.
Okay, great. We have to wrap on that note because we are out of time. Thank you very much for being here. I'd like to thank my two guests tonight, Martin Entwistle and Michael Dinneen, who I interviewed remotely. Thank you for watching. Visit our website, www.futuretalk.net. I'm Marty Wasserman. See you next time.